patients, our attitude towards the patients and the parents also who are accompanying the child actually. So before jumping into the examining the child, you should be explaining to the parent that you are not going to hurt the child by doing the maneuvers which you do to examine the child. So you are going to twist and you are trying to reduce it. The mother may think that you are going to hurt the child. The child may be crying, but you have to comfort the mother and say that you are not going to hurt the child. Second thing is, the child is always going to have a startled response when you are going to put your cold hands over them actually. So it's always better you rub your hands, make it warm so that you give some comfort to the child before going for examination. So I am going to start with the diagnosis, and we are going to go through the clinical findings and a little bit of scoring, because scoring is very important. So if you are going to remember the scoring, you are not going to miss any of the deformities you are going to show to the examiner, or you are going to examine the child. So the diagnosis, as we discussed since morning, so it's like you are going to tell that it's a case of idiopathic congenital talipes equinovarus, and you are going to comment whether it is unilateral or bilateral, and we are going to do a bit of scoring here. So why congenital? Congenital, it's the deformity present since birth. So there are conditions which can cause an acquired equinovarus deformity, equinocaverous deformity, like the one shown here where the child has equinocaverous, but again, see, the child has a scar in the midline, meaning that it's of a neurogenic origin. The patients can have foot deformation following a trauma. The patients can have foot deformation following a burn contracture. So it's essential, or it's very important to know when the deformity is existing from. The second thing is, never ever miss to examine the back in any patient coming with foot deformations. Not only for congenital talipes equinovarus, but for any foot deformation, you have to examine the back as a whole, and also the child as a whole, or the patient as a whole. So here, we are able to see a scar here, we are able to see a tuft hair along with foot deformation. And also, you have to remember the telltale signs of a neurologic origin, like a tag of skin here, a sinus, or a patchy nevus, hairy nevus. And also, while examining these foots, they are showing paucity of movements, as well as a simple way to elicit or to observe whether the child has neurologic involvement is to just gently stroke the sole of the child. So here, if you see again, the child was showing some movements on the left side, whereas the right side there were no movements, meaning that there is a neurologic involvement here. You can see it again. Okay, why idiopathic? So we know that there are other reasons for clubfoot, like the ones shown we were discussing in neurology cause. Also, we are talking about examining the child from head to toe. So there are certain conditions where it is associated with the foot deformation. For example, this is the only picture I have taken from internet. So this is a case of Freeman-Sheldon syndrome, where you have a microstomia, the mouth, a small opening of the mouth, or you can call it a whistling face. But remember, when you examine the child, these kids with orthobrachosis multiplex congenita will have multiple contractures of the adjacent joints, which can be evaluated. There can be fixed contractures, and there can be involvement of either more joints or the distal type variety. So these kids are to be differentiated from the idiopathic type, because the management may be a little bit prolonged and you may not be able to obtain the complete correction while doing the casting. Again, this is a case of amniotic band syndrome, where you have multiple constriction bands here along with the foot deformation. So while management, in cases with high grade involvement, we have to go for a constriction band release before going for correction of the foot deformation. And there are cases where there may be involvement of bones in anomalies like a tibial hemimelia, which may be associated with a clubfoot deformation. So this is the importance of examining the child from head to toe. It is very important. Never ever miss examining the back of the child as well as the head to toe examination. So what are the clinical findings? So it is very obvious for a child who is presenting with a congenital talipes equinovarus. You want to be able to appreciate that the dorsal aspect of the foot is facing laterally and the plantar aspect is facing medially. It is twisted in such a grotesque manner. And classically described, the foot is small and bean shaped as shown here, and you will have a convex elongated lateral border and a concave shortened medial border, and also you will be having a medial crease here. Again, the lateral border curvature can be visibly demonstrated by using a pencil or a scale which is placed along the lateral border, and you can appreciate from where the foot deviates medially. And also the heel is small and high riding because of the equinus deformation, which causes the calcaneus to be in flexion, and thereby the heel is small and high riding. And if the child is walking on this deformation for a longer duration, you will be able to appreciate that there are callosities formed on the lateral aspect or the weight bearing area, which is again a telltale sign that the child has been walking long enough with the deformation. So like the one shown here, and in neurogenic cases there may be breakage of the callosity causing a trophic ulcer also. And remember, this is a guy 24 years old who had been treated for clubfoot. So their foot is going to be small, the limb is going to be atrophic. So the calf circumference is going to be reduced when compared to the other side, as well as the foot is going to be small when compared to the other side in these kids. So the deformities, you can easily remember them as cave, that is cavus, adductus, varus and equinus. So when an examiner is asking you to demonstrate these deformities, the examiner is going to see from how or where you are examining these deformations. For example, a cavus is an elevation of the medial arch of the foot, and you have to see it from the medial side in the sagittal plane, and that is how you are going to examine it. And an adductus is best demonstrated from the plantar aspect, where a line that bisects the heel usually passes through the second metatarsal or between the second and third metatarsal. But if there is a medial deviation of the forefoot from the hind foot, so it is going to be adductus deformation, and it is better demonstrated from the plantar aspect. So if he is going to tell you, show me an adductus deformation, it's better to show him the plantar aspect and then demonstrate the deviation. And again, if you are going to show varus, you have to show it from behind, because this is from behind, it's better perceived. So here the foot is deviated medially, the hind foot, the calcaneus is medially deviated in relation to the leg, and this is the normal relation where it is in neutral or laterally deviated. So this is a valgus of heel, it's a varus here. And equinus, it's better demonstrated from the lateral aspect in a sagittal plane deformation where there is a tibiotalar plantar flexion deformation. So the scoring, I told you, it's very important to remember the scoring nowadays, because the scoring not only helps you to know the progress of management and to take some decisions, but it also helps you to remember the clinical findings that you are going to demonstrate to an examiner actually. So it's better to remember like a midfoot and a hindfoot score. The midfoot score is a medial crease, the curvature of lateral border of foot, and the lateral part of head of talus being palpable. So I will just touch this part, other things you can read upon. So it's the posterior crease, equinus and empty heel where you see in the hind foot. So the score is given from 0 to 1 and it's totally 6, and these are the midfoot score, and let's see this part actually. So this is the specimen dissected from the Ponseti's green book. So here you are able to appreciate this is talus, this is lateral aspect, and this is medial aspect. The naviculum and the entire this is called the calcaneopedal block. This has been shifted medially, deviated medially. So normally you are not able to palpate the talar head on the lateral aspect, but in these kids you will be able to do that. And also if you see here this specimen, this is the talar head here, and here is the calcaneum. So when an examiner asks you to place your thumb against the talar head, you should remember that you have to slide along the fibula, come to the lateral malleolus and come down and anterior. If you go down and inferior, you are going to place your thumb against the calcaneus or the calcaneocuboid joint, which is the method of manipulation followed by kite. And placing your thumb against the talar head is the method of manipulation by Dr. Ponseti. So here again, the clubfoot mimicking the specimen here, we are able to see the talar head here. So the finger is slided over the talar head and the foot is manipulated in this manner. So this is another video here. So we are palpating the fibula, you come into the lateral malleolus and you slide your thumb down and anterior. So here you are able to see the talar head also, and you are able to feel it clearly. If you go down and inferior, you are going to go to the calcaneum or the calcaneocuboid joint. So this is how the foot is manipulated. So this is the hindfoot score. Yeah, just one. This is the hindfoot score. And few questions, the relapse or recurrence foot. So these terms are used interchangeably in all literature actually. Relapse or so the literal meaning of relapse is worsening of the deformation while you are managing. But even in Ponseti's articles, he has used the relapse term even after the foot has been completely corrected and recurrence of deformation. And according to him, the most common deformities to recur are the equinus and the varus deformation. When you have to start casting, on a lighter note, in a breech delivery, when you are having the foot with a club foot coming out, you are supposed to cast before even the head comes out. but it's better to cast whenever, as early as possible, to get a good results actually. And if there are multiple deformations like the dislocation of the hip, dislocation of the knee along with foot involvement, which one is the first to be managed? So you manage the knee first because you know that a cast has to be applied in a flexed knee, followed by foot and then a hip management. So we depend on what Kite's method actually rather than error. I told you it's placing your thumb against the calcaneal cuboid joint rather than placing it against the head of talus actually. Two things, one is postural, it's correctable, completely correctable deformation, and it doesn't require multiple casting like the original clubfoot. And metatarsus adductus, it doesn't have the hindfoot deformation like a clubfoot, a hindfoot deformation of equinus and varus, and you have the deviation from the tarso-metatarsal joint with a space between the two toes here. If the cast slips while management, so it's going to create a complex clubfoot where you have these kind of foot which are swollen, short, the dorsum is edematous, the great toe is shortened and it's hyperextended, and you have rays running from medial to lateral aspect. Thank you.
Thank you, Nirmal. Any question, please? Yes, sir.
Can you tell about the use of the CTEV shoes? CTEV shoes.
Yeah, I will tell my what I